Erdafitinib was recently approved in 2019 for the treatment of an FGFR3 altered urothelial cancer. We were very pleased to have a new therapy to add to our armamentarium for the treatment of urothelial cancer, especially as we felt this may reflect an unmet need for the treatment of urothelial cancer patients. There was early data suggesting the FGFR3 altered tumor appears to be a more immunologically cold tumor without much of an immune infiltrate. And the concern was these tumors may not benefit as much from an immune checkpoint inhibitor as they would for treatment with an FGFR3 targeted therapy. We recently had publication in the New England Journal of Medicine of the phase 2 clinical trial of erdafitinib for the FGFR3 altered urothelial tumor. 99 patients were enrolled on this trial, and when you look at the population of patients treated, they really reflected a heavily pre-treated population with poor clinical outcomes. About 50% of patients had at least 2 or more prior lines of treatment, 70% of patients had visceral metastases, and over 50% had a creatinine clearance less than 60 mils per minute. So again, a population of patients with historically very poor clinical outcomes. Despite this, we were very gratified to see an objective response rate of 40% and a median overall survival of 13.8 months. So I think everybody was very happy with these results because historically taxanes, single-digit response, single-digit survival, it did appear we have a novel therapy that is going to impact patients' lives. As a result of this, there's further work being done. We have the THOR clinical trial, which was designed to test the concept, does the FGFR3 altered tumor benefit more from immunotherapy or from treatment with FGF-targeted therapy? There's 2 cohorts in this trial. Patients who've had prior chemotherapy but no prior immune checkpoint inhibitor are randomized to either erdafitinib or to treatment with pembrolizumab. And using this trial, we hope to answer that question. Does the FGF-altered tumor benefit more from FGF targeting or from a checkpoint inhibitor? There's a second arm on the trial for patients who have had prior immunotherapy, and that group of patients is being randomized between erdafitinib and single-agent taxane, which has become the de facto standard in this setting. In addition to this trial, we are building on the early evidence and the idea that erdafitinib could potentially enhance an immune response by combining it with an immune checkpoint inhibitor. There's the NORSE trial, which uses erdafitinib plus or minus citrilimab. Citrilimab is a PD-1 targeted agent being developed by Janssen. And what we're seeing at this year's GU-ASCO are first results from the phase 1 dose escalation portion of the clinical trial. When we look at erdafitinib in the phase 1 portion, it does appear to have a promising response rate. The unconfirmed PR and CR rate was 66%, and the confirmed PR and CR rate, although shown as 44% on the poster, we had recent notice since the printing of the poster that there's one more confirmed response, bringing the confirmed PR and CR rate up to 56%. It is the typical dose used on the phase 2 trial and on the THOR trial of 8 milligrams daily, up titrated to 9 milligrams daily dosing. So the trial is currently accruing in the randomized portion where patients are being randomized to erdafitinib or erdafitinib plus citrilimab to see how this combination may impact the response or the duration of benefit for our patients.